Hi, Dr. Masters again with Austin Addiction Medicine Associates. I'm going to talk to you today about practical advice for heroin addicts and opiate addicts seeking outpatient treatment. The problem associated with getting outpatient treatment is that there is so much unnecessary stigma associated with methadone and buprenorphine. A lot of people in our society don't understand the use of methadone or buprenorphine, and so the purpose of this video is to help you to understand some things about the pharmacology of the various substances that are used to treat heroin addiction or opiate addiction, and also some background on the criteria for entering methadone treatment or buprenorphine. But before we do that, we sort of need to back up and talk about opiate dependence in general. First of all, opiate dependence is a disease. It is not a weakness of character and inability to deal with life, a case of chronic wimphood, or a moral failing. It is a real live neurobiologic disease. Frequently, addicts become addicts because they have a genetic predisposition, they're raised in a dysfunctional family, there's often a history of early childhood physical or sexual abuse. They frequently have concurrent psychiatric disorders like anxiety, depression, bipolar, ADHD, etc. And they have access to alcohol and drugs. So that's the seed, so to speak, that gives rise to the birth and flowering of the addiction. Typically, people who do opiates tend to be rather monogamous with opiates. Once they begin doing opiates, they generally tend to see opiates and cigarettes or nicotine as their two primary drugs, and they may abuse certain other substances from time to time in combination with opiates, but opiates become mainly the focus of their existence. Now, it's not really true that everyone who is exposed to opiates becomes an opiate addict. What we know from medicine is that 27% of people who undergo elective outpatient surgery and who wind up requiring narcotics for pain, 27% of those people will go on to develop a dependency on opiates. And so we see the dependency rate for opiates at about 27%. So about a quarter of the population is susceptible to opiate dependence. That means that 3/4 of the population can do opiates periodically, recreationally, and not get addicted. But of course, we're talking about the addict population. The addiction is characterized by obsession with the drug, the development of tolerance, the compulsive use of the drug despite adverse life consequences, and those adverse life consequences have to do with problems involving romance, finance, health, family, work, or the legal system. So typically when people come to treatment, either in an outpatient doctor's office where they would receive buprenorphine or at a methadone clinic, typically they've been doing high-dose opiates for a prolonged period of time. The criteria for admission to a methadone clinic is that you must have been doing opiates daily for over a year. And unfortunately, when you do high doses of opiates for a prolonged period of time, in other words, you shoot dope every day for a year, in 95% of cases, you change the underlying wiring of your brain. And you're always going to need to see a certain amount of stimulation of those opiate receptors. Otherwise, you're going to experience craving or withdrawal, or even if you get through the acute phase of opiate withdrawal, which lasts anywhere from 7 to 10 days on average, even if you get through that, the number one cause of relapse to opiates is what I call opiate deficiency dysphoria. And opiate deficiency dysphoria is different than depression. Depression is sad, weepy, tearful, potentially suicidal, and it tends to get better with antidepressants. Opiate deficiency dysphoria is different. The patient appears depressed, but they're not suicidal. However, they wouldn't mind if they died because their life is meaningless, joyless, and purposeless without some underlying stimulation of those opiate receptors. And so we see this time and time again. The biggest problem that people have when they get into methadone treatment is that they're in a big hurry. They want to come into methadone treatment, take the minimum amount of methadone for the minimum amount of time, they're going to wean off of it, and their life is going to be great. That never happens. Double underline, never happens. Why? Because short-term detox with opiates doesn't work. There's a 95% relapse rate, okay? So what is the purpose of methadone, or son of methadone, which is buprenorphine? What is the purpose of those medications? It's to eliminate drug craving, eliminate dope sickness. And if I have you on the right dose and you shoot dope, guess what? You just wasted your money because you're not going to get high. Your receptors are blocked. Now, if you enter treatment and we get you up to a dose of methadone that eliminates drug craving and eliminates dope sickness, then you're just going to feel normal. You are not going to feel high. Now, if you combine methadone with cocaine, benzodiazepines, methamphetamine, alcohol, marijuana, well, then you're going to get a boost, okay? Or get high, so to speak. But if you do that, you are not really in recovery. The people who are in recovery are the ones who are taking the medication as I dispense it. Why does methadone get a bad name? Methadone gets a bad name because we treat people with methadone to get the needle out of their arm. Why? Because the death rate associated with opioid dependence is 2.5 times the death rate for a combat soldier in Vietnam. So if you are a frontline combat soldier in Vietnam, your chance of dying is 3%. Smoke a pack a day for 20 years, 1% per year. Alcoholic, 0.5% per year. Shoot dope, 7.2% per year. When you come into methadone treatment, that figure falls down to 1.4% per year. So we continue to do harm reduction. We give methadone to addicts because it gets them off the street. It gets the needle out of their arm. For many of them, 70 to 80%, it gets them back to work, it gets them back to school, it gets them to be functioning human beings, all right? And it markedly decreases criminality. So it's a very, very valuable treatment, but it's highly misunderstood within the community. Addicts coming into treatment frequently want to get better just like that, and it doesn't happen like that. So what does the composition of a methadone clinic look like? Well, 50% of people who come to methadone are still active drug addicts. They're just using methadone as a backstop until they can get more heroin, or they're combining it with other drugs to get a boost. The other 50% are evenly divided into 25% of the total will eventually wean themselves completely off methadone. The other 25% of the total will never do anything harder than caffeine or nicotine. They'll take methadone, perhaps lifelong. They will have jobs, pay taxes, send kids to college, and have average American lives. So, methadone is a highly misunderstood and highly underused medical technology for improving survival in the setting of opioid dependence. The government recognized this back in 2000 when they passed the Data Act of 2000, which established the use of buprenorphine, also known as Suboxone or Zubsolv, as a drug that could be used by outpatient primary care clinicians who could prescribe it to opioid addicts and give them the same benefits that methadone gives people who are in a methadone clinic. So what's the main difference between methadone and buprenorphine? The main difference has to do with the fact that methadone can only be prescribed to a narcotic addict in a methadone clinic. Buprenorphine, as I said earlier, can be prescribed in a methadone clinic, but more commonly it is prescribed in an outpatient clinical setting, and monitoring for methadone treatment is very intense. So if you have someone who has a very high tolerance rate, they're shooting a gram or more of heroin a day, and they need close surveillance with frequent urine drug screens, contact with nurses and counselors, etc., then a methadone clinic is basically the way to go. However, if you have someone who has a relatively low level of tolerance and has a job, particularly if they travel, then usually buprenorphine is the best way to go. What are the average doses of methadone that are used in a methadone clinic? Well, to begin with, your dose will be determined by your doctor, who will make that determination based upon how much heroin or opiate you are currently using. So generally speaking, someone who's using half a gram of heroin a day or more usually will start at 20 milligrams or 30 milligrams, depending upon the judgment of the clinician. Definitely someone who is using a gram a day will probably start at 30 milligrams, which is the top dose you can give in the first 24 hours. The dose will then be gradually escalated. Usually, let's say the patient comes in, they're shooting a gram and a half of heroin a day. I'll give them 30 milligrams the first day. The second day they come back, they'll get 40 milligrams. At 40 milligrams, practically all of their physical symptoms of withdrawal will be relieved, but they will still be experiencing craving. So they keep coming back to the clinic, they keep getting dosed, and we gradually increase the dose of the methadone. A lot of times addicts are in a big hurry to get comfortable, and that can create problems because methadone has a long half-life, and you don't get your maximum effect from a change in dose for up to 5 days after the dose, because methadone's got a half-life of about 32 hours, all right? So you change the dose on day 1, and you don't reach maximum effect until day 6. So you have to be careful, especially during the first 2 weeks, of increasing the dose too rapidly, because you don't want people to overdose. The other thing that's really, really important that opiate addicts must understand is that combining benzodiazepines like Xanax, Klonopin, Valium, combining those drugs with methadone or buprenorphine is a recipe for death, okay? Death due to respiratory depression, all right? So don't come into a methadone clinic expecting to get Xanax or Valium or something like that. We don't do that. The other thing to understand is duration of treatment, all right? Look, you didn't become addict overnight. You are not going to be weaned off of methadone or buprenorphine overnight. In the setting of buprenorphine, I recommend a minimum 18 months of treatment before attempting to wean the drug. In the setting of methadone, I recommend a minimum 36 months. So come into the program, relax, sit down, get comfortable, and as you remain sober, you will find that your life is getting better. What's the first thing you'll notice? You got money in your pocket and you can make rent. I hope this helps. Thank you.